Okay, I'm Sally Thorne. I'm a nurse and a professor here in the School of Nursing at UBC. And much of my research over the past 40 years has been in the field of cancer, particularly human experience of cancer, the intersection between the attitudes and structures we set up for cancer care and how people actually receive it, the communication we do in cancer care, and more recently, complex communication around end of life and medical assistance in dying. I've been quite involved with cancer for quite a few years. At one time, many years ago, I was actually the chair of the board when there was a public board of the BC Cancer Agency. And I've never had a job at BC Cancer, but I have worked collaboratively with clinical colleagues and research colleagues all of these years. I've done a lot of research with patients who have had cancer in the BC Cancer system. So I know, I've heard a lot of stories from a patient perspective about what cancer care is like. Well, as a nurse, I have taken care of cancer patients as well. And it's very clear that cancer care has highly technical, increasingly technical aspects for which the science is evolving and incredibly complex and interesting and fascinating, but that it's human beings going through for what for many of them is the most profound and difficult thing that they've ever experienced. For people and their families and their friends, it evokes all kinds of challenges, things to worry about, things to think about, decisions to make, revisions in your life plans. Those are profoundly deep and difficult psychosocial kinds of experiences. And we in nursing really do pay an awful lot of attention to that. We know lots of the technical, and there's a great deal that we do that is clinically focused and supporting the more medical aspects of the treatment. But there's a great deal to do to try and optimally shepherd people through those very complex and difficult and evolving experiences. Well, I think the obvious one for many people, and certainly for certain groups of people, populations within society and cultures, is that cancer is inevitably a fatal illness. And so being diagnosed with cancer tends to be one of those profoundly life-changing, the heavens open and somebody's mortality is right in front of them. Those are, most people who have had cancer remember vividly those moments of being diagnosed. And the things that are said and done with and to you at those times can really shape the degree to which you can have any trust in the system going forward, which is incredibly important. So if that moment of diagnosis is a kind of harsh, factual, we don't really care about you, we're just telling you technically what the pathology says, or this looks like a very serious cancer, there's probably nothing can be done about it. If those negative messages are given at the time of diagnosis, that can really set the stage for a distrusting and difficult experience going forward. And so I don't think people necessarily understand, well, to me, the work that I do is mostly in the communication end, and I think that we need clinicians, we need oncologists that are very smart people and understand the science and understand it in the evolving way. But we shouldn't let them have sort of unassisted conversations with people if they don't happen to be people who can develop those communication skills and have the emotional intelligence to be able to convey complex and difficult messages to people at really difficult times in their lives. So those are issues we're working on. Most oncologists are fantastic. Anybody who's had cancer will probably recognize that most put a lot of effort into that. But our systems have not known how to weed out or deal with those few who are probably technically competent, but socially incompetent and cause a lot of harm. So trying to create communication safety for all people so they will feel respected, they'll understand the information, they'll be able to ask questions they need to ask. Those are some of the things we're trying to work on in the cancer system. Well, we do. Every good cancer hospital or agency, every good cancer system will give communication training. Medical students get communication training. But it's insufficient. Because some people will take it up and take it seriously and spend the rest of their lives continuing to learn and looking at role models who are great communicators, trying to figure out how do you talk about this complex situation, how do you explain this. So some value it and will spend their whole lives. Because communication is not something you just learn 3 things to say and you've got it. It's an evolving, ongoing, questioning, developing process, running into new and different situations and trying to work out, running into different kinds of patients and realizing, that didn't quite work. What do I do from here? So it's a very complicated skill. There are some, though, that either never do understand why it's important, who routinely violate any normal rules of communication behavior. There's nothing more we can do kinds of statements that unfortunately far too many people hear. There may not be another treatment that you can provide, but there is always something that the healthcare system can do for people. So that's the kind of thing I mean by a fundamental violation. That the penalty light should go off and say misconduct penalty. We should not allow those things to happen. So unfortunately, while most cancer patients receive good communication most of the time, also a great many of them, far too many of them, will recognize a time in their cancer experience when something was said to them that was really quite unfortunate. And it's those things that cause you to, not sleep at night and ideas keep coming back. Things like being told you've got an 83% chance of this succeeding. Like, what do you do with information like that? Like, people just agonize. If I eat something differently, if I go do yoga, if I go and get some alternative treatment, do I increase that to 87%? I mean, people don't know how to deal with statistical information, for example. Saying you got a 50-50 chance of something or other is it has some statistical relevance in a human life. You either get well or you don't. And 50-50 means we don't know. That's all it means. And yet people, sometimes they turn those messages into a statistical report because it sounds more authoritative. It sounds more scientifically based, when in essence, it's a way of communicating. We do not know which way this will go. Well, I know that there are people who simply move into research for research's sake, and you can take courses to learn to be a basic researcher, which is most likely to be part of a research team and doing some of research tasks. But I truly believe that the ability to understand what are the most important researchable problems comes from being in the professions, in the fields that have something to do with cancer care or health care, or social work, or psychology. So that because I don't think I would have identified the nature of problems that I have studied over the course of my career if it hadn't been from my perspective of a nurse of human beings going through phenomena. Because at that time it wasn't particularly fundable, it wasn't, the high priority science, it was difficult to get published and things like that. But we've evolved over time. We have much more patient-oriented research. We have much more qualitative research, which tends to look at the complexities of human experience and not just try and categorize people into little ticky boxes, but to try and bring those experiences to life. So I think that being in one of those professions that has an angle of vision that tells you what needs studying is one way forward.